Good afternoon, everyone. Thank you for joining us today for the Long-Term Care Hospital Quality Reporting Program Provider Training Webinar covering the LTCH QRP Achieving a Full Annual Payment Update. My name is Rachel Boglai, and I will be your host and moderator today. Our agenda today includes 1. An overview of the LTCH QRP, 2. The LTCH Continuity Assessment Record and Evaluation Dataset, as well as submission and reporting requirements, 3. The Internet Quality Improvement and Evaluation System, 4. Determining compliance with the LTCH QRP, and 5. We will end the webinar by providing additional resources, followed by a question and answer session. At the conclusion of this program, we would like training participants to be able to, 1, recall the basics for the LTCH QRP.
Number 2 is to identify the LCDS submission requirements and data submission threshold. 3, to describe the steps related to LCDS data submission and acceptance. 4, discuss the application of various IKEYS reports. 5, describe the impact of the LTCH QRP data submission on the annual payment update. And 6, identify one resource for providers related to each of the topics presented. Now I would like to introduce today's speakers. Ms. Christy Hughes is a Center for Medicare and Medicaid Services Long-Term Care Hospital Quality Reporting Program Coordinator. Christy earned her master's degree in healthcare administration with a focus on project management. Ms. Hughes previously worked in a leadership role within the MedStar health system. Ms. Teresa Mota has over 27 years experience in geriatric nursing and is currently an associate nurse researcher at APT Associates. Prior to joining APT, Ms. Mota worked for the Centers for Medicare and Medicaid Services as a post-acute care subject matter expert in quality measure and standardized data assessment development across post-acute care settings, assisting with the implementation of the IMPACT Act and standing up the SNF QRP.
Slides 6, 7, and 8 in the slide deck contain a reference list of acronyms that will be used throughout today's presentation. Now, I will review a few housekeeping items. This webinar is being recorded. It will be posted to the CMS LTCH QRP website, and we will provide you with details on accessing the recording via email when it becomes available. The phone lines will be on mute for the duration of the presentation. If you need technical assistance during the webinar, please let us know by using the Q&A panel to the right of the presentation. Additionally, you can use the Q&A panel to submit your relevant content-related questions. We will end the webinar today with a Q&A session and will address as many of the questions submitted as time allows. To the right of your screen is an important information panel. This panel contains information on using your phone to dial into the webinar, a link to the slides being presented, as well as how to access live closed captioning features in your browser. If you need assistance accessing this feature, please let us know using the Q&A panel. Throughout today's event, we will be using polling questions. The polling questions allow the speakers to gauge your understanding of the material being presented. Each polling question will appear automatically on your screen. Please review the answer choices offered and submit your response by clicking on the circle to the left of your response. You can change your answer at any time before the poll is closed. Your answers are confidential and will only be reported in aggregate percentages. Let's try out the polling function with our first question. You should now see the polling question appear next to the presentation on the webinar screen. The question is, how many people, including you, are joining this webinar together in the same room? A, just me, I'm the only one participating. B, 2 people. C, 3 or 4 people. Or D, 5 or more people. So let's give everyone a moment to select their response. And it looks like we have the majority of people, so let's go ahead and broadcast the results. And it looks like the majority of people are attending by themselves. Let's try a couple more questions. The second question is, which president signed Medicare into law? A, Richard M. Nixon. B, Lyndon B. Johnson. C, Dwight D. Eisenhower. Or D, Gerald Ford. Let's give everyone a couple of moments. Looks like we still have some coming in, so we'll give it another moment. And let's go ahead and broadcast the results. The correct response is B, Lyndon B. Johnson. For our third and final practice question, who was enrolled as the very first Medicare beneficiary by President Johnson? A, Harry S. Truman. B, Claudia Alta Lady Bird Johnson. C, Richard Nixon. Or D, Betty Ford. Let's give it another couple of moments here. And let's go ahead and broadcast the results. The correct response is A, which is Harry S. Truman. As a reminder, we will conclude the event today with a final wrap-up and a Q&A session. If you have any questions throughout the presentation today, please submit them via the Q&A panel on the right side of your screen. It is now my pleasure to turn the session over to our presenters, Ms. Christy Hughes and Ms. Teresa Mota.
Hello, everyone. Let's go ahead and get started. We're going to get started with the basics. What is the LTCH QRP? What are the CMS quality goals for LTCH care? What are the LTCH QRP quality requirements? And what is the relationship between quality reporting and the APU or annual payment update? The LTCH QRP was established in fiscal year 2012. It was in response to the Improving Medicare Post-Acute Care Transformation, otherwise known as the IMPACT Act. The IMPACT Act requires public reporting of quality measures related to LTCH care, as well as the submission of standardized patient assessment data elements, otherwise known as SPADs. Using the standardized quality measures and standardized data, the intent of the IMPACT Act, among other obligations, is to allow for the exchange of standardized and interoperable data among the post-acute and other providers. The IMPACT Act intends for standardized post-acute care data to improve Medicare beneficiary outcomes through shared decision-making, care coordination, and enhanced discharge planning. CMS has identified quality health care for Medicare beneficiaries as high priority, and we define quality as effective and efficient quality care provided for all beneficiaries, regardless of personal characteristics that meets the patient's needs and preferences, delivered safely and timely. All Medicare certified LTCH facilities are required to collect and submit data from the LTCH Care Dataset, or the LCDS, for all patients receiving inpatient services, those who are admitted to, discharged from, or expire in the LTCH, regardless of the length of stay. And the LCDS data are required to be submitted and accepted within the threshold and according to the established submission timelines. Let's take a look at how quality reporting and the APU fit together by looking at the LTCH QRP Life Cycle for fiscal year 2022. There is a 2-year delay between data collection and the effective fiscal year application of the APU. For example, on this slide we see that the data collected was in calendar year 2020, and it will be used in support of the fiscal year 2022 APU. The first piece involves the LCDS data collection and submission. The data collection and submission that impacts the fiscal year 2022 is collected from January 1st through December 31st of 2020. During the first half of 2021, CMS will review the data submitted and make a compliance determination. In late June or early July, they will send out non-compliance letters to providers. I want to note that only providers identified as non-compliant are going to receive a letter. Following the issuance of the non-compliance letters, there's a 30-day provider reconsideration request period. This process occurs in July and August. In September, providers who have submitted a reconsideration request within the 30-day period will receive a letter informing them of the reconsideration results. We will walk through the specifics of the life cycle later in the presentation. Now, let's review the LCDS submission and reporting requirements. Let's start by talking about the LCDS in general. The LCDS is completed for all Medicare certified LTCH facilities, for all patients receiving inpatient services who are admitted to, discharged from, or expired in the LTCH, regardless of length of stay. It is the assessment instrument used for collection and submission of data elements that are necessary to calculate the quality measures as mandated by the LTCH QRP and the SPADES and QMs specified under the Impact Act. The data elements in the LCDS are to be standardized and interoperable to allow for exchange of information among PAC providers and other providers, access of longitudinal patient information, coordination of care. The current version of the LCDS is the LCDS version 4.0, which was implemented July 1st, 2018. The LTCH Care Dataset, the LCDS, is applicable to all patients receiving services in a facility certified as a hospital and designated as an LTCH under the Medicare program. The data collection using the LCDS is applicable regardless of patient's age, diagnosis, length of stay, or payment payer source. The LCDS includes admission, planned discharge, unplanned discharge, and expired assessments. These data sets are completed for individual LTCH patients who are admitted to, discharged from, or expired in the LTCH. Currently, the data submitted for the LTCH QRP quality measures are derived from 3 different data sources. There's the LCDS, the Centers for Disease Control and Prevention Healthcare Safety Network, referred to as the NHSN, and the Medicare Fee-for-Service claims. It is important to understand that APU is based on the submission of data elements used to calculate the QMs and not on the QMs themselves. The LTCH QRP is a pay-for-reporting program and not a pay-for-performance program. For the NHSN, CDC requires data submission on a monthly basis and strongly encourages healthcare facilities to enter each month's data within 30 days of the end of the month in which it is collected. For example, all March data should be entered by April 30th, so it has the greatest impact on infection prevention activities. However, for purposes of fulfilling CMS's quality measurement reporting requirements, each facility's data must be entered into NHSN no later than 4.5 months after the end of the reporting quarter. So in other words, Q1, consisting of January, February, and March, data must be entered into NHSN by August 15th. Q2 must be entered by November 15th. Q3 must be entered by February 15th, and Q4 data must be entered by May 15th for data to be shared with CMS. Let's look at the assessment-based quality measures currently adopted for the LTCH QRP and whether higher or lower percentages are better. So, for the changes in skin integrity post-acute care, pressure ulcer injury measure, lower percentages are better. For the application of percent of residents experiencing one or more falls with major injury during a long stay measure, lower percentages are also better. But for the change in mobility LTCH patients requiring ventilator support functional outcome measure, it is displayed as a change score. For the percent of LTCH patients with an admission and discharge functional assessment and a care plan that addresses function measure, a higher percentage is better. For the application of percentage of LTCH patients with an admission and discharge functional assessment and a care plan that addresses function measure, higher percentages are also better. And finally, for the drug regimen review conducted with follow-up for identified issues, post-acute care LTCH QRP measure, higher percentages are also better. For the compliance with spontaneous breathing trial, or SBT, by day 2 of the LTCH stay measure, higher percentages are better. And for the ventilator liberation rate measure, we're also wanting higher ratios. They are better. Finally, for the 2 transfer of health information measures, higher percentages are better. I do want to note that while the 2 transfer of health measures were finalized in the fiscal year 20 IPPS LTCH PPS final rule for adoption, in the LTCH QRP, the delay in the release of the updated versions of the LCDS needed to support the collection of the associated data elements has been delayed to provide maximum flexibilities for LTCH in response to the COVID-19 PHE. Now, let's take a look at the other data source, the claims-based quality measures. For the first measure, the rate of potentially preventable hospital readmissions, 30 days after discharge from an LTCH measure, lower rates are better. For the rate of successful return to home and community from an LTCH measure, higher rates are also better. And finally, for the Medicare spending per beneficiary for patients in LTCH measure, it is displayed as a ratio. Now, let's take a look at the final data source, the National Healthcare Safety Network, NHSN, QM. For the catheter-associated urinary tract infection, or CALT outcome measure, lower rates are better. For the central line-associated bloodstream infection, or CLABSI outcome measure, lower rates are better. For the facility-wide inpatient hospital onset Clostridium difficile infection, or CDI outcome measure, lower rates are better. For the final measure, the influenza vaccination coverage among healthcare personnel measure, higher rates are also better. Now, taking a look at this chart, the chart displays the LCDS data submission deadlines. The data collection year is a calendar year, and the data submission deadline is approximately 4.5 months after the end of the data collection submission. The August 15 dates may differ depending on if the date falls on a holiday or a weekend. CMS will provide reminders for upcoming data submission deadlines on the LTCH QRP Spotlight Announcements webpage and provides fiscal year LTCH QRP data collection and final submission deadline documents as a download on the LTCH QRP Data Submission Deadlines webpage. We would like to note that there were temporary changes to the data submission requirements due to the COVID-19 public health emergency, and those are listed on this table. The data submission was optional for Q4 of 2019 and accepted for quarters 1 and 2 of 2020. Since Q4 was optional and data submission was strong, these data were included in measure calculations for public reporting. We were missing data for Q1 and Q2 of 2020, which will impact what is displayed on the Care Compare for LTCHs. Since the temporary exception for LTCH quality reporting requirements ended on June 30th, 2020, Starting on January 1st, 2020, LTCHs were expected to resume timely quality data collection and submission of measure and patient assessment data for the LTCH Care Dataset and NHSN. There are no submission requirements for the Medicare claims data. There are two separate data completeness thresholds required for compliance with the LTCH QRP. The LCDS threshold is 80% of LCDS data submitted must contain 100% of the required quality data elements for the 10 assessment-based QMs. Additionally, CDC NHSN threshold is 100% of the required NHSN measure data collected and submitted using CDC's NHSN. LTCHs that fail to submit the required data by the data submission deadlines will be subject to a 2% point reduction of their APU for the affected fiscal year. This chart again illustrates the relationship between the data collection year and the fiscal year APU that will be impacted. As I mentioned earlier, there is a 2-year delay between data collection and the affected fiscal year application of the APU. For example, data collected in calendar year 2021 will be used to support of the fiscal year 2023 APU. This table shows that beginning on January 2021, CMS will begin freezing or holding data constant on the Care Compare site for the remainder of 2021. Public reporting will resume in January of 2022. CMS is aware there will be impacts regarding the LTCH QRP exceptions due to the current public health emergency, including discharge assessments submitted on or after July 1st, 2020 may not have a matching LCDS admission record if the admission occurred in Q1 or Q2 of 2020. And that may cause an out-of-sequence warning, otherwise known as 909, during the submission process. Please note that despite these warnings, data will still be accepted into the KEYS ASAP system. CMS will make adjustments to accommodate any records with missing admission assessments. These mismatched sets of records will not be counted or included in your LTCH data calculations for Care Compare. We have already talked about the LCDS data collection requirements and the data submission timelines, but it is also important for providers to ensure the LCDS data are accepted. Please understand that the act of submitting data does not equal acceptance. Now, let's look more closely at the LTCH submission requirement for the LTCH. The assessment reference data, or A or D, must be no later than the admission date plus 2 calendar days. The LTCH Care Dataset, or LCDS, admission assessment should be completed no later than ARD plus 5 calendar days, i.e. no later than the admission date plus 7 calendar days, but also may occur on, but not after the ARD. The completion date is recorded in item Z0500B. We will see more of this on the next slide. The submission date should be no later than completion date plus 7 calendar days, i.e. no later than admission date plus 14 calendar days, but also may occur on, but not before, the ARD. The LCDS plan discharge assessment is completed when a patient is non-emergently medically released from care at an LTCH for longer than 3 days for some reason that was arranged in advance. The assessment period begins 2 days prior to the date of discharge, with the actual date of discharge being the end of the assessment period. However, some items refer back to the admission assessment. The ARD must be equal to the date of discharge. The completion date should be no later than the discharge date, plus 5 calendar days, and also may occur on, but not before the ARD. Submission must be completed no later than the completion date, plus 7 calendar days, and also may occur on, but not before the ARD. The LCDS's unplanned discharge assessment must be complete if a patient has a transfer or unplanned transfer to another hospital facility and does not return to the LTCH within 3 calendar days. Other examples include leave the LTCH against medical advice, decision to go home or to another hospital or facility. The assessment period begins 2 days prior to the date of discharge, with the actual date of discharge being the date of the assessment period. The LTCH should complete an LCDS discharge assessment to the best of its ability given the nature of unplanned discharges. The completion date should be no later than discharge date, equaling 5 calendar days, and also may occur on but not before the ARD. Submission must be completed no later than the completion date plus 7 calendar days and may also occur on but not before the ARD. Now we will discuss the LCDS expired assessment. This must be completed when the patient dies in the LTCH. However, it should be noted that if the patient dies during the admission assessment period, both an LCDS admission and the LCDS expired assessment must be completed. The ARD must be equal to the discharge date, which is the patient's date of death. The completion date should be no later than the discharge date plus 5 calendar days, and also may occur on but not before the ARD. Submission must be completed no later than the completion date plus 7 calendar days, and also may occur on but not before the ARD. The last assessment to be discussed is the interrupted stay and LCDS assessment completion. First, let's discuss what program interruption is. Program interruption refers to an interruption in a patient's care given by an LTCH because of transfer of the patient to another hospital facility per agreement for medical services, such as the need for acute care services, such as interruption must not exceed 3 calendar days. In these cases, the following applies. If a patient is returning to the LTCH after more than 3 calendar days, which is the day of transfer plus 2 calendar days, at another facility or hospital, then an LCDS discharge assessment related to the transfer should be completed and a new LCDS admission assessment should be completed. If a patient is returning to the LTCH after a stay at another hospital lasting less than 3 calendar days, then an LCDS discharge assessment related to the transfer should not be completed and a new LCDS admission assessment should not be completed. If the patient did not return to the LTCH by day 3 of the transfer, it is no longer considered an interrupted stay, and the LTCH should complete an LTCH care data set planned or unplanned discharge assessment as appropriate. The LCDS records are submitted to the CMS IQ system. To aid in the submission process, you will want to ensure that your submissions are in the correct format, contain the correct information, and will be accepted by the IQs. The IQs Report Training Guide is an important resource for providers. So to ensure that the data you have submitted are accepted, the IQ system will confirm that the submission was received. But it is important to stress that that confirmation of submission is not the same as acceptance of the submission. The LTCH Provider Final Validation Report, or the FVR, will verify acceptance of rejection of LCDS records. So let's take a pause here. A question about the information we have covered so far. The question is, where do you submit LCDS for the LTCH QRP? Is it A, the Nursing Home Serva Data Center, B, Centers for Disease Control and Prevention, C, the Quality Manager at your agency, or is it D, the IQs? Okay. All right. It looks like most of you have provided an answer. And the answer is D. At this time, I will return the presentation over to my colleague, Teresa Mota from APS Associates.
Hi everyone, thanks Christy. In this section, I will provide an overview of IKEY's reports, specifically the final validation, review and correct, and provider threshold reports. I'll be discussing how each of these reports can be used to check compliance with the LTCH QRP. First, just to let you know, we're going to be showing you some screenshots from the IKEY system throughout this part of the presentation. It may be a little bit difficult without actually being in the application itself, but by providing the screenshots, we hope it'll help you locate this information when you're actually in the application, especially if you've never actually been in IKEYs to access these reports. Also, please keep in mind that the IKEY system is updated periodically, and the current view may differ from these screenshots that are in the presentation. Once you log into IKEYs with your user ID and password credentials, the Welcome to IKEYs page appears. From that Welcome to IKEYs page, you will select the Reports tab at the top of the page. A drop-down menu will appear. You would select the second option, which is Find a Report, and when you select Find a Report, a new web page appears with a list of available report categories and types. There are many valuable reports in the IKEY system, and the ones I will be discussing today obviously will be specific to the LTCH setting. So the third option in that original drop-down that you saw on the previous slide, that drop-down says My Reports. If you choose this option, it takes you to a web page within IKEYs that provides you the opportunity to access and manage your available reports. So when you go in to look at a report, you can actually save it into this area, and you can organize them into folders for your own future use and reference. This graphic provides an overall review of quality reporting, and as you can see, there are three reporting categories listed here. So there's IKEYs reporting, and you can see it at the top. Over to the lower left, you see confidential reporting, and over to the right in the green area, public reporting. The review and correct reports, the provider threshold reports, and the quality measure reports are all confidential reports that provide you with the ability to review and analyze underlying data to ensure that the data you have submitted was and is accurate. The provider preview report is also a confidential report, but this report provides a preview of the data that will be reported on Care Compare, which you see in the public reporting section of this overview, all the way to the right. Today I'll be reviewing only those reports that will help support you in determining whether you're maintaining compliance with the LTCH QRP requirements, as there are many, many reports available in IKEYs. So the three reports, as I said before, I will be reviewing are the final validation report, the review and correct report, and the provider threshold report. So the LCVS final validation report, also known as the FVR, is an automatically generated report in IKEYs and is available within 24 hours of file submission. This report is placed in the provider's My Reports folder in IKEYs. This report provides detailed information about the status of select submission files. It's critical for you to ensure that submitted records have been accepted. Submission alone does not mean that the records were submitted, the records that were submitted were accepted. And of course, this is important when it comes to compliance with the IRF QRP requirements. If a record gets rejected, the facility must correct the errors identified in the FVR and resubmit the record to IKEYs. Failure to correct and resubmit those records may jeopardize compliance not only with the LTCH QRP, but it will also affect the LTCH quality measures that are reported. The FVR will indicate for you whether the records you submit for each file were accepted or rejected. It details the fatal file or record error or warning messages that the system encountered. While the FVR is auto-generated, it can also be user-requested. And one reason for this is that the report is only in the system for about 60 days. So if the report is removed from the system folder before you could print it or save it yourself in that My Report section that I mentioned, you can actually rerun the report using the same information for that particular period. It's recommended that as a provider, you make it your habit to go in after each submission go into that folder, look at your FVR for that submission, and make that part of your regular process. What that does is ensures that you're aware of the errors and warnings that were generated, and it provides you with an opportunity to take action on that information. So this is a screenshot view from iKeys of the Find a Report option under the Reports tab that I spoke about. Once in iKeys, at least 24 hours after submission, you can request and retrieve the final validation report by selecting Provider Reports from the Report category drop-down menu, which you see over to the right. So you would choose Validation Report from that report type drop-down and select Find Report. This is actually what the LTCH FVR will look like once you access it. Again, these are just snapshots of the reports, so you can at least see what they look like. They might look a little different from the report as you're accessing it directly from the system. The top portion of the FVR will contain the details of the file, such as the date and time the file was submitted, the ID of the user who submitted the file, facility-specific information, and a summary of the submission statistics of the records in the zip file. Beneath this is information about each LCDS record processed by iKeys, including record and patient-specific information, as well as any error messages that were returned by the system for that LCDS record. So let's talk a little bit about those errors and warnings that you'll see on the LTCH FVR. As I've stated, these errors and warnings are intended to help you identify issues with LCDS submission and acceptance. Identifying and correcting issues related to the submission of records to iKeys helps you to maintain LTCH QRP compliance. There are many conditions that may prevent a file or record from being successfully submitted, and the FVR will tell you whether or not the error is fatal, meaning that the record has not been accepted, or simply a warning, meaning that the record will be accepted, but the data submitted may be something you'd like to ensure is accurate. Warnings affecting APU, or the annual payment update, occur when there is missing data. An example would be a discharge goal not entered for a GG item, or dashes on data elements used for measure calculation. Each error or warning has an identifier that you can cross-reference in Section 5 of the LTCH Provider User's Guide, which is available on the QTSO website. This section of the guide lists all of the errors, warnings, and includes guidance for correcting errors if necessary. Remember that all fatal errors in a file or record must be corrected and the file or record resubmitted. For fatal file errors, these are identified as the submission file structure is checked against data submission specifications. If the file doesn't meet the required specifications, the file can be rejected. Examples of a fatal file error could be that the file was submitted as a single record and not contained within a zip file, or there was something in the file that caused the system to be unable to read it. Remember that files that are rejected due to fatal errors must be corrected and resubmitted. So what I just described was a fatal file rejection. However, it can also be rejected if a record within that file contains a fatal error. Again, these errors are identified as each LCDS record within the submission file is checked for fatal errors against the data specifications. Examples of fatal record errors might be an out-of-range response, such as when a valid response for an item is outside of the responses that the system is expecting. So for example, if the responses for a data element are 1, 2, and 3, but the value submitted for that data element was 6, you'll get an error. Another type of fatal record error might be an inconsistent relationship between items, such as an inconsistent date pattern, like having the patient's birth date, which is item A0900, being in the same year as the admission date into the LTCH, which is item A0220. Just like fatal errors, fatal record errors cause a file to be rejected by iKeys, which means that the record was not accepted. Rejected records are not saved in iKeys. And again, a reminder that any fatal records or files must be corrected and resubmitted in order to ensure data are accepted. So you may also receive non-fatal errors or warnings. For example, when an LCDS record is submitted late, you'll receive a non-fatal warning letting you know that the record was submitted late. Records that only contain warnings or non-fatal errors are accepted into iKeys, but it's still important to review these non-fatal errors to ensure that the data submitted is accurate. Anytime there is a fatal error, no matter whether there are non-fatal errors included, the record will be rejected and must be corrected. Remember, even if there's just a warning error, it doesn't mean that you shouldn't review them to see whether the information needs to be corrected and or resubmitted. So here's an example of an error warning page in Section 5 of the LTCH Provider Users Guide that I mentioned. As you can see in this sample page, the error ID that you'll find on the FDR is listed, and that would be in the left-hand column. And then it lists the severity of the error, which is the second column. In the first case, you see a fatal error related to inconsistent response pattern, meaning that the provider entered a response into an item that's outside of the responses that the system expected, like I mentioned before. The description column gives you the cause and potential actions to rectify the issue. The second example shows the warning 3900, which is the warning for a data element that's associated with the APU payment reduction due to the use of the dash. Again, the error description column gives you the cause and potential actions to rectify the issue. So let's move on to the review and correct report. These reports are user-requested, on-demand reports and are available and accessed in iKeys in a similar manner as the FDR, but by choosing the quality reporting program from the report category drop-down list and then selecting the review and correct report from that report type drop-down list that we saw in the other snapshot. These reports, as I stated, when going through the overview, are confidential to providers. The information on the report provides both the quarterly and cumulative performance rates for the assessment-based publicly reported quality measures at both the facility and patient level. You are able to request data specific to a particular QM, and the data can also be exported to a CSV flat file. It's important to understand that the quality measure information on these reports are not risk adjusted. You will only see observed raw data on these reports. When you request the data, what will display are the 4 most recent quarters, as this information is provided in rolling quarters. What that means is that once a new quarter of data are added, the oldest quarter of data are dropped. The review and correct report does not provide APU status on its own, but it can be used in conjunction with other reports to help ensure data accuracy, which is important for APU compliance. It's a quick way to look at the raw data, check and see if a quality measure might be an issue, so that the provider can then go and investigate and confirm the accuracy of the underlying data. Review and correct is specifically given to facilities so that they can correct any underlying data that may be erroneous before the data submission deadline is closed and before any data gets publicly reported. As I stated, only observed or raw data are provided. The risk-adjusted rates are not shown. These reports are available for providers to run with updated weekly data until the data correction deadline. So once that deadline is passed, the quarter's data is going to be rolled off, as I just mentioned, and you will not be able to correct that data. But remember, each week the system will be updated with new data. So when that reporting quarter ends, data for the new reporting quarter will be available as early as the next day. That is, the quality measure data are refreshed weekly and on the first day of the quarter. This report will also display the data correction deadlines and whether the data correction period is open or closed. And again, this is important to know because if you do find something on the review and correct report that leads you to believe underlying data are incorrect, meaning the submitted data might have been erroneous, you will only be able to correct that data when the submission deadline for that data is open. Once the data submission deadline is passed and the data submission period is closed, you cannot update the underlying data. As you may recall, due to the COVID-19 public health emergency exceptions, there will be no data available to correct. That is, you will see that for Q1 2020 and Q2 2020, the data correction period will display as closed. So here are some fields that you can sort for patient-level data that are available in the Review and Correct reports. You can sort patient-level data by last name, by first name, by the resident's status, their discharge date, and admission date. You can also sort this data by individual quality measures. So here's a table with a reminder of those LTCH QRP data submission deadlines and the correction periods I mentioned. The final submission deadlines for the LTCH QRP are based on quarterly data collection timeframes, and all the LCDS data must be finalized prior to the submission deadline. Looking at this table, you can see that, for example, data collected for Q1 in any particular calendar year is data that covers January 1st through March 31st, and the time frame for when you can review and correct the submitted data from that quarter is April 1st through August 15th. This same pattern holds through for the other 3 quarters of data. When a submission date falls on a weekend or a major U.S. federal holiday, the system automatically accepts provider submissions up to midnight of the following business day. CMS will also notify and remind providers when the data submission dates fall on a date other than the 15th. The data correction deadlines are for dates that are used to calculate the publicly reported measures and are not applied to the confidential quality measure reports. Remember that there will be no data available to correct, that is, the data correction period will not be open, for Q1 and Q2 of 2020 due to the COVID-19 PHE exceptions. So here's a snapshot of what a review and correct report looks like for facility level data. As you can see, the report header consists of the report title and the number of pages, the facility's ID, their CCN, name, city, and state, as well as the requested quarter, the report release date, the report run date, the data calculation date, and the report version number. Beneath that, you will see the quality measure displayed. Here it's showing just the application of fall's quality measure, and then the table legend just above the data table. The table legend shows you what the time frame, what the following characters mean within the table. If you see a dash, it means that the data is not available or applicable for the measure. An X means that the measure was triggered. NT if the measure was not triggered. Or if you see an E, the measure was excluded from analysis based on the quality measure exclusion criteria. And then there's the table headers, which include the reporting quarter, CMS ID, start date, end date, data correction deadline, and then whether or not the data correction period is open or closed. In our example, we have 1 open quarter, 3 closed quarters, and the next column indicates the number of stays that triggered the measure. This is followed by a column with the number of LTCH stays in the denominator, and then finally you see the facility percent for the quality measure for each of the quarters. So let's stop here for a second and think about what you do if a measure is triggered. Let's look at what the patient-level data table tells us. Remember, we get this data by checking off that box on the report criteria selection screen that says we want to receive the quality measure information at the patient level. Here you can see that the headers for this report for each reporting quarter selected displays the patient's name, first and last, the patient ID, which is auto-generated by the system, the admission date, discharge date, data correction deadline for that particular quarter, whether the data correction period is open as of the run date of the report, the patient's status. Remember that you can filter for this specific status information for whether the quality measure was triggered, not triggered, excluded, or whether the data was not available nor applicable or dashed when running the report. Finally, let's take a look at the LTCH Provider Threshold Report, or PTR. This report is accessed from the Quality Reporting Program report category, just like the Review and Correct report, but by selecting Threshold Report from the report type drop-down list. The PTR provides details on the status of the measures required for the annual increase factor, for the annual payment update by fiscal year. It, like the review and correct report, is user requested and on demand. The provider can specify the fiscal year of interest, and for that fiscal year, the report will display the number of successfully submitted patient assessments and the number of patient assessments submitted that were complete, as well as the percentage of those assessments that were submitted as complete. The LTCH PTR displays an asterisk for future monthly and quarterly dates when a measure is active but the data are not yet available in the system. LTCH QRP Provider Threshold Report allows providers to monitor the compliance status of the required data submission for the LTCH Quality Reporting Program measures for the current annual payment update by fiscal year. So here's a snapshot of the PTR. The LTCH QRP PTR details the following for the specific fiscal year: the number of LCDS assessments submitted and the submitted complete, as well as the percentage of LCDS assessments submitted complete. Let's look at each of these in more detail. The number of LCDS assessments submitted provides the total number of assessments submitted within the quarter and submitted to CMS by the data submission deadline for the data collection start and end dates that were selected. This is the denominator. The next number is the number of LCDS assessments submitted complete, which provides the total number of assessments identified in the denominator that don't contain dashes for any required data element used to determine the APU compliance for the LTCH QRP for that applicable fiscal year. This is the numerator. And finally, the percent of LCDS assessments submitted complete provides the calculation result of the numerator, which again is the number of assessments submitted complete. And that's divided by the denominator. Again, it's the number of assessments submitted. The LTCHs with a percentage under 80% are determined to be non-compliant with the LTCH QRP. Additional information about IKEY's reports can be found on the IKEY's YouTube site. This link can be found on this slide and is also found within IKEY's under training. Okay, that was a lot of information presented on these IKEY's reports, but let's pause to check our knowledge. So here's the first question on the report. Which report provides detailed information about the status of select submission files? Is it the LTCH Final Validation Report, the LTCH Error Summary by Provider Report, the Review and Correct Report, or the Provider Threshold Report? You see quite a few people putting in their responses, some changing them. Okay. I'm going to wait another second or two because I see a few people going back and forth on some reports. Okay, I think we can display the correct answer now. So the correct answer is A, the LTCH Final Validation Report. Okay, let's try another one. Which of the following statements regarding the Review and Correct Report is false? It can be requested on demand. B, is confidential to providers. C, provides only facility-level quality measure data. Or D, displays 4 most recent quarters of data. Quite a few people vacillating between C and D. Okay, it looks like we've got some folks with B, C, and D. I'm going to give it a couple more seconds as I see people continue to respond. Okay, I think we can broadcast the response, the correct answer. All right, and the correct answer is actually C, and that's because the Review and Correct Report provides only facility-level quality measure data. This is false. So remember, we were looking at the false statement because the Review and Correct Report provides both facility and patient-level data, not just facility-level quality measure data. And with this knowledge check complete, I'm going to turn the presentation back over to Christy from CMS, who'll be talking about compliance with the LTCH QRP. Christy?
Thank you, Terry. Yes, I am back. So we're going to talk about determining compliance with the LTCH QRP, and we're going to explore the process. For the purpose of calculating compliance with the LTCH QRP, LCDS data submissions for the calendar year are reviewed against the requirements of the LTCH QRP. Those requirements include the submission and acceptance of LCDS admission assessment, followed by a planned discharge, unplanned discharge, or expired assessment. The LCDS data are required to be submitted by established quarterly deadlines, and 80% of the assessments received must contain 100% of the data required to calculate the LTCH QRP quality measures. You may recall that this was discussed briefly earlier during our discussion of the provider threshold report. The numerator contains the number of assessments completed with 100% of the required LCS data elements, and the denominator contains the number of assessments submitted before the submission deadline. The result of the calculation yields the LCDS threshold percentage. Here's an example. 100 assessments were submitted on time. Of those, 95 contained 100% of the required data elements, resulting in a 95% threshold, and that is compliant with the LTCH QRP LCDS data reporting requirements. So compliance with NHSN for the LTCH QRP includes reporting of data for each calendar month with 3 months worth of data due by the quarterly submission deadline. Providers are to report instances of HAIs for the required measure, even if there were no infections, and the summary data and reporting plans. Providers that submit complete data for all 12 months will be compliant with the NHSN portion of the LTCH QRP compliance. Please note that for the submission of the influenza vaccination coverage among healthcare personnel measure, only data from Q4 of the prior year and Q1 of the current year must be entered by May 15th following each influenza season. Any LTCH that is found non-compliant will receive a letter of notification from their Medicare Administrative Contractor, otherwise known as MAC, which will include instructions for requesting reconsideration of this decision. In addition, all Medicare-certified LTCH compliance letters will be distributed electronically into the non-compliance notification folders within IKEYS for each LTCH to access. This letter also includes the reasons for failing APU compliance. You will also find news and updates on the IKEYS Technical Support Office webpage. Again, only those providers considered non-compliant and subject to the reduction in their annual percentage unit will get a letter. Compliant providers will not receive a letter. Now let's get more specific about what is a reconsideration. Reconsideration is a request for review of the initial CMS compliance determination for a given LTCH for a given fiscal year. If an LTCH has been identified for the 2-point percentage payment reduction in the APU, they have the right to request a reconsideration of the non-compliant decision. So why would an LTCH submit a reconsideration request? Well, first, the LTCH must receive a notice of non-compliance in order to file a reconsideration. LTCHs must submit a reconsideration request if they believe that CMS finding of non-compliance was an error, or if they have evidence of the impact of extraordinary circumstances which prevented timely submission of data. Requests for reconsideration must be submitted within 30 days after the date of documented on the noncompliance notification letter. When creating a reconsideration request, it is important to note that the reconsideration request must be submitted via email to CMS at the email address below and must contain a subject line of LTCH ACA 3004 reconsideration request and the LTCH CMS certification number. Do not submit reconsideration requests to the MAC. You must be sure to include the information below in your request. You'll need the CCN, business name and address, the CEO or designated contact information, the CMS identified reason or reasons for noncompliance from the notification letter, the reason or reasons for requesting reconsideration, and information supporting the LTCH's belief that either the finding of noncompliance is an error or they have evidence of the impact of extraordinary circumstances which prevented timely submission of data. The reconsideration request must include documentation demonstrating the LTCH's compliance, including proof of submission, email communications, data submission reports from IKEYS, previous waiver approvals, copy of the CCN activation letter, and other documentation that will support the LTCH's rationale for seeking reconsideration. And it is important to be aware that determination will be made based solely on the documentation provided. CMS will not contact the LTCH to request additional information or to clarify incomplete or inconclusive information. Reconsideration requests that contain protected health information or PHIs will not be processed. After the reconsideration request is submitted to CMS, CMS should acknowledge receipt of the reconsideration request within 5 business days through an email. Following its review of the request and supporting documentation, reconsideration request decisions are distributed by the MAC and the reconsideration contractor in a trackable way, such as FedEx, USPS with tracking. If the decision upholds the finding of noncompliance, a provider may appeal with the Provider Reimbursement Review Board, or PRRB. Information about the PRRB and the appeal process can be found on the cms.gov PRRB review webpage. So here's a summary of reminders of the reconsideration process do's and don'ts. You should, or do, send reports demonstrating compliance with all PHI redacted. You should submit your reconsideration request prior to the deadline. You should ensure that you receive an email confirmation of receipt in addition to the automated response from the mailbox. Don't. You should not submit a PHI. You should not submit an email that is larger than 20 megabytes, and you should not submit reports from third-party vendors. A PHI tip if submitting the FVR as part of your reconsideration process, be sure to check the update fields, as these often contain hidden PHI. If any assessment was updated after the initial submission, those updates are listed on the FVR. Here's another reminder about the estimated reconsideration process timeline. So from June to July, the non-compliant LTCHs that failed to meet QRP requirements are notified. From July to August, the reconsideration requests are due to CMS no later than 30 days from the date of notification of noncompliance. CMS will provide an email acknowledgement within 5 days upon receipt of reconsideration requests. In September, CMS will notify the LTCHs of the decision on reconsideration requests, and in October, the APU penalty is imposed on LTCHs found to be noncompliant with QRP requirements. And now, some additional notes about the APU. CMS annually updates the Medicare fee-for-service prospective payment rates provided to LTCHs who are billing MACs for services provided to Medicare beneficiaries. This is called the LTCH APU. This APU occurs on a fiscal year basis every October 1st. LTCHs that do not meet the reporting requirements of the LTCH QRP are subject to a 2% point reduction in their APU. Okay. Now, let's review the graphic presentation of the LTCH QRP Life Cycle from submission of data to application of the APU one more time. As I stated earlier in the presentation, January to December, the data are submitted. June and July, providers are informed if non-compliant, and July and August is the reconsideration timeframe. I will note that it is only a 30-day reconsideration window. In September, providers are informed of reconsideration results, and October 1st, APU is implemented for the effective fiscal year. Now I'm going to turn the presentation over to my colleague, Teresa, to talk about the resources available. Teresa?
Thanks, Christy. So as we've gone through this presentation, we've mentioned some resources and links along the way for you to access. Here in this section, the links and resources have been compiled together for easier access. I would recommend that you go to each link, review the information, and download and save any of the resources that you would think helpful to you. You also can bookmark them in your internet browser so that you can access them easily. So here are the resources for the LTCH QRP webpage, where you'll find the most current LTCH QRP manual and item sets. The webpage that details the LTCH reconsideration and exception and extension process is also included on this slide, as is the CMS resource for NHSN users. And here are the iKeys resources discussed during today's training in the screenshots to the right as to where you can locate them in iKeys. And here are the links to all of the help desks that are available to you. There are help desks specifically for the LTCH QRP, including a general help desk, a public reporting help desk, a reconsiderations and APU compliance help desk. There are also help desks related to the iKeys system and the support website for iKeys. As a program, the LTCH QRP team has provided many in-person trainings, webinars, video vignettes, web-based trainings, and printable resources for LTCH. These trainings and training resources can be found on the LTCH QRP training webpage. This concludes the presentation portion of the webinar. So I'm going to turn the reins back over to our facilitator for today to queue up the question and answer session. Rachel?
Thank you so much. So with the time remaining today, we would like to answer some of the questions submitted through the Q&A panel. So let's see. The first one here is, can you tell me how I can get started with the long-term care hospital quality reporting program? Christy?
Sure. So to be compliant with the LTCH QRP, overall, LTCHs must comply with the individual requirements of the LCDS and the NHSN measures data reporting. There is a document in the download section of the LTCH QRP Data Submission Deadlines webpage. It's called the LTCH QRP Quick Reference Guide. Please go to the Centers for Medicare and Medicaid Services site under the LTCH QRP and bookmark that webpage. Once you're on the page, you can scroll all the way down to the download section, and you will see a document titled PAC LTCH Quick Reference Guide version 1.0. This is going to help guide you in starting the process, and the document can be found under that download. Thank you.
Okay, thank you. So the next question I have here is, when speaking about the iKeys reports, you mentioned that there are warning messages and fatal errors. Can you talk more about the differences between the two? Terry?
Okay, thanks for the question. So warning messages alert you to inconsistencies or issues that you should be aware of or might want to address. But with a warning, the issue isn't severe enough for the system to reject the record. The records with only warning messages are still going to be accepted into iKeys. So examples of warnings could include late submission warnings, inconsistent responses, or date issues. In contrast, the LCDS records that receive fatal errors, they're not accepted into iKeys. So you'll definitely want to monitor your final validation reports for these errors so that you can address and resubmit any rejected records to be sure that those LCDS records are accepted. See the error IDs associated with each data element. You can refer to the detailed data specifications that can be found on the LTCH QRP Technical Information webpage. And to get descriptions for each error ID, the potential causes for the error, and the tips on how to correct it, you're going to review that in Section 5 of the LTCH Submission Users Guide that we spoke about during the presentation. An additional resource is Chapter 4 of the LTCH QRP manual, which goes over submission and correction of LCDS records. That's another good resource for you. And all of these manuals as far as the LTCH QRP manual and the LTCH care data set, they can all be found on CMS's LTCH QRP website. And if you look at the left navigation, it lays it out pretty nicely where you can find the majority of the information you're going to need.
Thank you, Terry. Here's another one for you. How often would you recommend that we run the provider threshold report?
It's a really good question. It's really up to each facility to decide how often it wants to run these reports, but I would think that monthly is probably a good idea. It's a good routine to get yourself into, because running the PTR monthly is going to help you determine if you're having issues maintaining compliance with the submission requirements for the QRP. So checking the PTR at least monthly is going to give you enough time to correct any issues before it's too late to do anything about them. So during the presentation when we discuss compliance, the compliance is determined by whether or not the LTCH has met the compliance thresholds for both the LCDS assessment data and submission, as well as the measures data to the CDC via NHSN.
Thank you. So the next question here is, our facility did not receive a letter of non-compliance. Does that mean that we are compliant with the LTCH QRP? Christy?
Yeah, so during the presentation, we discussed that compliance is determined by whether or not the LTCH has met the compliance thresholds for both the LCDS assessment data submissions as well as the measure data for the CDC via NHSN. So if an LTCH fails to complete 100% of the required data elements on at least 80% of the LCDS assessments as required under the LTCH QRP, and they also fail to submit 100% of the measures data through the NHSN as required, they will receive a notification from CMS. This notification is going to come in the form of a non-compliance letter. CMS sends this letter via the MAC by mail or email, and also the non-compliance notification folder in their iKeys. But you should be looking for a letter in the iKeys around June or July. And remember that if you are compliant, you're not going to receive a letter. And you should be checking your PTRs regularly for the details about your compliance percentage throughout the year.
Thank you. So Chrissy, here's another one for you. What percentage of LCDS submissions are required this year to avoid the annual payment update reduction?
Sure. So the data submission threshold for the LCDS records related to assessment data to be collected during the calendar year 2021, it's 80%, and it affects the fiscal year for 2023. Don't forget that you must be compliant with NHSN measures data submission as well. So that requires all measures be 100% and be reported to the CDC via NHSN as required in order to avoid an APU penalty.
Okay, thank you, Christy. The next question I have here is, we've heard a lot about the LTCH QRP today, but can you explain what Care Compare is? Terry, can you take this one?
Sure. So Care Compare is a streamlined version of the what were the 8 existing CMS healthcare compare tools available on Medicare.gov. So if you recall, there used to be an LTCH Compare. So the new website provides a single user-friendly interface that consumers of healthcare and caregivers can use to make informal decisions about healthcare based on cost, quality of care, volume of services, and other types of data. So like the original LTCH Compare, it's where LTCH providers will have the ability to look at the quality measures that are publicly displayed. We encourage providers to inform their patients and family members about the new Care Compare website and explain that the Care Compare website provides a snapshot of the quality of care particular to post-acute care providers. They can encourage patients and their families to review quality ratings and offer assistance in understanding what's available to them on the website. And you can get to Care Compare by just literally typing in Google Medicare Care Compare, and the first link is what will bring you to Care Compare.
Awesome. Thank you so much, Terry. The next question here is, what is the penalty for not submitting the required data by the data submission deadline? Christy, can you take this one, please?
Sure can. Okay, so since we're in calendar year 2021, the associated reporting year is fiscal year 2023 APU reporting year. So if you fail to meet LCDS submission requirements this year and you also fail to submit measure data to NHSN as required, your APU is going to be reduced by 2 percentage points for fiscal year 2023. And this payment penalty is going to last the duration of the fiscal year involved, which in this case would be fiscal year 2023.
Thank you. So another one on submissions. I have been submitting my LCDS assessments and NHSN data. Why did I receive a notice that I'm not compliant?
Well, for compliance with the LTCH QRP, providers are required to meet 2 separate thresholds. The first threshold is an assessment submission threshold of 80%. And again, this means that at least 80% of all the qualifying LCDS assessments have 100% of the required LTCH QRP data elements reported. These are the data elements needed to calculate the LTCH QRP quality measures and are defined as the standardized data elements. And then again, the second threshold is a measure data submission threshold of 100% for NHSN. And this data is required to be reported to NHSN each calendar month with 3 months of data due by each submission deadline. So providers that submit the completed data for all 12 months, and that is 100% of the measures data, will be compliant with the NHSN portion of the LTCH QRP reporting requirements. If your LTCH failed to meet both of these thresholds mentioned, you would have been issued a letter of noncompliance. Now, the LTCH, you can run the PTR to obtain your current threshold for the LTCH QRP and the FDR to verify data submission to IKEYS. And if you are reviewing your assessments for a vendor, we suggest that you look at the FDR to verify your submission to the IKEYS. Now, although the NHSN reports were not reviewed during this presentation, the best method to verify your current NHSN data submissions is by running the CMS reports found in the analysis report section of the NHSN. You can find some detailed guidance on how to run and interpret the CMS reports and all other NHSN reports, as well as a checklist used to ensure complete reporting into NHSN. And that can be found at the CMS resources for NHSN users website. And if you have any questions regarding these reports within NHSN, just please contact the NHSN Help Desk, and their URL is nhsn@cdc.gov, and they'll be able to help you out with that.
Okay, thank you, Christy. So this next question is about error messages. How can I identify which assessments have error messages? Terry?
Yeah, that's another good question. So as I said, there are other reports that you can run in IKEYS, and this is one that we didn't go over. But you can run the assessments with error number XXX report. And the XXX stands for the actual error ID. So when you look at your FDR, remember that first column is going to show you the error ID. You can actually enter up to 5 error ID numbers in that error number XXX report. So, for example, if you look up error messages 3900, 3933, and or 3954, those relate to items that, if dashed, may result in not meeting the required APU minimum submission threshold. You should also run any of your FDRs to confirm that your assessments have been successfully submitted, and take a look at the review and correct reports to determine if the data you're looking at are in the reporting quarter where the data correction deadline is open, so that the underlying data can still be corrected if needed. And as we said kind of at the beginning of this presentation, you kind of have to look at all of these reports in concert to really kind of dig and see if you're compliant, because not any one of them in particular will relate to that APU compliance. So Section 5 of the LTCH Submission Users Guide, which is available on the QCSO website, contains the information on those error messages. And again, you can review Chapter 4 of the LTCH QRP manual to understand how to correct assessments that need to be corrected. And again, those manuals are found on the LTCH QRP website. And if you go to that main website again and look at the left navigation, it lists out, LTCH QRP manual and data set, LTCH training. So it's all there for you on that main LTCH QRP webpage.
Thank you, Terry. We have another question on some of the reports. So I do not understand why we are not compliant. The review and correct report shows that we're at 100%.
Okay. So remember that the review and correct reports will provide data by measure and by quarter, both at the facility and patient levels. Of the provided quality measure results for 4 rolling quarters, it identifies the open and closed status of each quarter's data correction period as of the report run date. Of note, the quality measure calculations are performed weekly and on the first day of each quarter, so you can get a pretty accurate picture if you pull the report weekly or at a minimum monthly. Important to remember that the review and correct report is not an APU report. It was developed to show providers to review their quality measure data to identify if any corrections or changes are necessary to, prior to the quarter's data submission deadline, which again is 4.5 months after the end of the quarter. It also gives the providers an opportunity to see their data calculated in a similar manner to the provider preview reports. You can always reach out to SwingTech at QRP Help at SwingTech, SwingTech.com, and sign up for quarterly emails. If you're not meeting APU requirements, they're really a good resource.
Okay, thank you, Terry. The next one is also for you. So I know that there are several help desks that LTCHs can use for questions. Can you tell me the difference between the LTCH Quality Help Desk and the Reconsiderations Help Desk?
Sure. So providers can email the LTCH QRP Help Desk for general questions about the LTCH QRP. So those could include LTCH QRP requirements, general quality reporting requirements and reporting deadlines, information about the LTCH QRP quality measures, LCDS coding instructions. You might also ask them questions about data reported in the review and correct reports or the quality measure reports. For the Reconsideration Help Desk, this is the help desk that you use to submit a reconsideration request to or ask other questions related just to reconsideration. So you might ask questions like how to file a request if you receive a letter of noncompliance, the deadline for filing a request for reconsideration, how to dispute any findings of noncompliance with the QRP, and requesting information about the LTCH QRP payment reduction for failure to report any of the quality data and things like that. You can, again, if you go to that LTCH QRP main web page, there is on the left navigation side of that web page, there is a help web page, and you'll see that right on the left-hand side. It says LTCH Quality Reporting Help, and all you have to do is click on that, and it'll bring you to the help page.
Okay, thank you so much. The next question here is for Christy. When is a new LTCH required to begin reporting LTCH QRP data?
Okay, well, if a hospital is classified as an LTCH for purposes of Medicare payments, it would be denoted by the last 4 digits of their 6-digit CMS certification number, their CCN, in the range of 2,000 to 2,299. It is subject to the requirements of the LTCH QRP. Data collection using the LCDS is applicable. It's regardless of the patient's age, diagnosis, length of stay, payment payer source. And the data collected must be submitted in the time frame, manner, and form established by CMS for the LTCH QRP. The applicable LCDS, our current version, is version 4.0, and that is admission, planned discharge, unplanned discharge, and expired assessments. They must be completed for eligible patients who have been admitted to an LTCH on or after 12 a.m. on July 1st, 2018.
Okay. Thank you, Christy. And it looks like we have time for one last question. So this one is also for you, Christy. I am trying to understand the difference between the exemptions and the extensions and the reconsideration process. Can you clarify the difference between these two?
Sure, and yes, it is confusing. So CMS recognizes that there are times when you have extraordinary or extenuating circumstances, and that can delay or prevent the submission of your required data. In those instances, you can get an exemption or an extension, such as in a natural or man-made disaster that prevents timely submission, or in a disaster that affects many providers in a wide geographic area, or perhaps just a single provider. These can be CMS-initiated or provider-initiated and can occur at any time throughout the year. If it is provider-initiated, it is important to include all the facts and circumstances that support your request. When an exemption or extension is granted, an LTCH will not incur payment reduction penalties for failing to comply with the LTCH QRP requirements for the period of which their exemption or their extension has been granted. Now, in contrast, the reconsideration is a request for review of noncompliance within the LTCH QRP. So you would have received that noncompliant letter, and you would be asking for reconsideration. The noncompliance decision is made prior to the 2-point percentage reduction in the LTCH APU, and if you recall from our discussion earlier, that APU reduction does not take effect until October 1st, so you do have time to submit your information. This period of reconsideration occurs only once per year, and only for the LTCHs that were determined to be non-compliant with the LTCH QRPs and could potentially be subject to that 2 percentage point reduction. If you want more detailed information regarding the extensions, exceptions, and the reconsiderations and the process for all, you can go to the CMS website for LTCH QRP and look at the Quality Reporting, Reconsideration, Exceptions, and Extensions webpage. And you're going to find all the links are listed on the slides at the end of this presentation today as well. And in addition, the presentation slides will be uploaded to the download section of that LTCH QRP page we keep talking about, but more specifically the training page. And you should see that within a couple weeks after this webinar.
Thank you so much. Yep. Thank you so much, Christy. I'd like to thank our presenters for sharing their knowledge on today's webinar. This concludes the Long-Term Care Hospital Quality Reporting Program Provider Training webinar. The webinar slides presented today, which will include the answers to the polling questions, as well as the recording of this webinar, will be posted to the LTCH QRP website. Once posted, we will send an email notifying you where to download all of the material. Thank you so much for attending, and please enjoy the rest of your day.